and live on YouTube. Thank you very much for joining us on today's Saturday evening. And I know there are a lot of conferences happening today, and there's a lot of academics happening as the last couple of weeks of the year approach. So that's a good way to end this year, I suppose, which hasn't been a very kind year for most of us. So welcome again. My name is Dr. Prasad Raj Dandekar. I head the Radiation Oncology Department at Sir H.N. Reliance Foundation Hospital. And in a couple of minutes, we will be starting our webinar where we are talking about two very important things that we are dealing with in our day-to-day life. One is managing COVID crisis, and the other is managing breast cancer patients. So just be with us for a couple of minutes, and we will go live in soon. So just a few instructions. So a few instructions for people who are attending. As you're aware, you are seeing this video on YouTube while we are actually in a Zoom room. So I request you to post your questions onto the YouTube link, and we will be taking those questions and addressing them at the end of the conversation. So we will have a series of lectures, and we'll gather all the questions and answer them, all of them, at the end of the session. So please feel free to ask all the questions that you want, and then hang on till the end to get the answers from the experts. So it is 4 o'clock now, and welcome again. My name is Dr. Prasad Raj Dandekar. I head the Radiation Oncology Department at Sir H.N. Reliance Foundation. And along with my team today, we are here to share our experiences of what has happened in the last few months from the context of COVID crisis, as well as treating breast cancer patients. As you're aware, breast cancer is one of the commonest cancers in India. In fact, in our clinical practice, we treat a large number of breast and head and neck cancer patients. So it's very significant for us to manage breast cancer patients during this crisis. And it has been a very difficult time for all of us in clinical practice. So we thought, let us share what we have been up to. Thinking of something positive that comes out of this year that we have had. First few months of the COVID crisis were quite difficult for all of us, and my colleague Jerin will be sharing with you what happened. But at some point, we as a team decided that, okay, enough is enough and we must get on with it. In month of May, we organized a webinar on the new trial that got published, and Dr. Amol, my colleague, will be discussing that trial in detail. And we did a webinar along with Dr. Rajiv Sareen and his team from Tata Hospital. And we sort of formulated how we can treat breast cancer patients more effectively through this COVID crisis. And today's webinar is a sort of culmination of that discussion where we are sharing our clinical data, our experience of not just physics point of view, but also clinical point of view. What are the toxicities or the lack of them with you in today's session. So as I mentioned earlier, we will be streaming this live on YouTube, and all of you will be seeing it on YouTube. I request all of you to post your questions on YouTube, and we will be taking them at the end of the seminar. And please hang around for all the answers. We'll first have Jerin to talk about the COVID management, then Dr. Amol will talk about clinical data, then Sunil will talk about simulation, Anand, our physicist, will talk about planning, and then Sunil will again talk about the treatment part of it. And then we'll take question answer session. So overall, I think a good 1 to 1.5 hour session. And we hope to have lots of questions to make it more meaningful and rich. So I'll hand it over to Jerin now. Jerin Matthew has been my colleague for last 11 years. He's an excellent radiation therapist with a lot of experience. So he will talk to us about how did we manage the COVID pandemic. Over to you, Jerin.
Okay, good evening, everyone. Thank you for joining. Thank you, Dr. Prasad, for giving me a chance to present this presentation in this webinar. Here, we just want to tell that how we manage our patients during this COVID-19 pandemic. So in the initial stage, we were that is in the month of Feb and March, we were treating patients with limited staff. There were only two therapists, one physicist, one doctor, and one nurse, and we were doing a treatment in alternate days. And we shifted the duty timing from 7 a.m. to 3:30 p.m. to reduce uh, the contact during transportation. And we were screened before entering the hospital. They used to check the body temperature, and if it is normal, then only they are allowed to come inside. And we were using grade 1 PPE while treating patient. And patient relatives were not allowed in the department. Only the patient is allowed inside the department. And in the beginning of April, there we faced one incident. Actually, we were supposed to plan a bilateral breast patient. We planned that patient. After the planning, the radiologist found out that there are some patches inside the lungs. And he declared that these are the symptoms of COVID. Immediately, we shifted the patient to COVID-19 hospital. The report came positive. So all the staffs who were in the department were sent for quarantine, and department was fumigated and closed. Everyone was in a panic mode. Okay, we don't want this situation to happen again. And we did some adaptation to our duty protocol to reduce such kind of incidents. So we did some adaptation for staff. For staff, we made it mandatory that this screening before entering the hospital we made mandatory. And if the temperature, body temperature is normal, then we were given this badge. You can see this green badge. Okay, so in the hospital premises, we were allowed to wear, we have to wear this badge. And all staffs are underwent weekly antigen test, and there were symptom checker. It was mandatory for each and every staff, and we were wearing grade 1 PP and grade 2 PP. Here you can see the blue one is grade 1 PP, and the white one is grade 2 PP. The difference is that the grade 2 PP have goggles, head cover, and leg cover, and the therapists used to wear the grade 2 PP because they are in more contact with the patient. And for identifying each other, we used to put our name and role in the PPE kits. And for patients also, we did some adaptation. So for patient also, we made this mandatory that there was screening before entering to the hospital, and these badges were given to them also. And for planning patient, we used to insist them to do a RT-PCR test within 48 hours. And if the report is negative, then only they are allowed to plan. We used to call them for plan. And for treatment patient, we are doing weekly tests for them. And daily the patient list, which include a patient, treatment patient, training patient, and planning patient, to the security in the entrance. And security will only allow that patient to come inside the hospital. And we made one form. This is called the COVID declaration form. So in this form, we will get more information regarding patient symptoms, patient family members symptoms, and any travel history and all. And we used to give this form in the with the consent, and patient used to fill this form and give to us at the day of planning itself. And you can see our OPD arrangements. You can see we are maintaining social distance even in the OPD. And along with the patient, only one relative is allowed to come inside the OPD. And you can see this is the patient waiting area. There also we are maintaining the social distance. And we schedule patient according to that. At a time, not more than 2 patients were there in the waiting area. And you can see our treatment, our departmental doors were kept open to reduce the contact with each other. because if we keep the if we keep the doors closed, every time someone has to open and close the door, and if someone is infected, then there are more chances of getting spreading infection to everyone. And along with this, we made one WhatsApp number, and we given to each and every patient, and we asked them to share their reports, and if for any emergency or any query, they used to reply in that WhatsApp number. So this reduces the contact between the oncologist and patient to a certain extent. And before this pandemic, we used to give a hospital uniform to patient, and they have to change their clothes with our hospital uniform, and then we used to treat. So when from the pandemic onwards, we have totally reduced that, and we are treating patients with their clothes itself to reduce more infection. And after each and every a patient's treatment, we used to clean our couch and the accessories which are using for the patient by using disinfectant. And whatever changes we made, we are following our Reliance Foundation core values, and we have given more importance to patient than anything. And what we are doing is a teamwork, it is not an individual contribution. And service we are giving is an excellent service. And in the conclusion, we should accept this situation and we should move ahead. Okay, and be ready to adapt. Means this is not a permanent solution, and this is a temporary solution, and in future we may face worse situation than this. So we should ready to adapt and communicate with each other. Like I have now shared my experience in our department with all of you, and you also should share your experience, like something incident happened in your working area. You should also share that experience, and if you have any suggestion to improve each and our this thing working structure, you can help us, and we should communicate with each other, and we can tackle this situation. And be safe, do hand hygiene, wear mask, and keep social distancing. Thank you.
Thank you very much, Jerin, for that very crisp presentation about our protocols and how our protocols also evolved over time. And I really, I agree with you that what has helped us to stay focused is being focused on our core values of patient first, excellence, and teamwork. And while we were all away during the COVID crisis, I felt that this crisis has helped our team to grow together because we all have been through so much in our professional as well as personal life, and we sort of held each other together through this. So it's been wonderful. And that's one positive then that has come out of this not so good year. So the next presentation is from my colleague, Dr. Amol Kakade. He is a consultant radiation oncologist in our department. He's trained in Tata Hospital and a very fine consultant, fine radiation oncologist. He's going to talk about our clinical experience about the hypofractionation and how we treated breast cancer patients and why we adapted this protocol and how we are managing that. Over to Dr. Amol.
Thank you very much, sir. And thank you, Jerin, for a wonderful opening talk. Hello, I am Dr. Amol. I will be talking about the clinical aspects of ultra-hypofractionation radiotherapy in breast cancer. I will take you through the journey of how the radiation treatment evolved in the patients of breast cancer and how this treatment and how we adopted the new ultra-hypofractionation protocol. Now, before we go on to talk about the radiation treatment in non-metastatic breast cancers, we first let's understand how non-metastatic breast cancer patients are managed. Now, any breast cancer patient initially is either an early breast cancer patient or a locally advanced breast cancer. And in that, we can see those patients who have early breast cancer, are either undergoing a surgery upfront in the form of breast conservation surgery or a mastectomy, or if the patient has a locally advanced disease, can undergo a surgery upfront, or can undergo a neoadjuvant chemotherapy if the patient wants to go for a breast conservation, and finally a surgery based on the response to the chemotherapy, which can be either a further a breast conservation surgery or it
Dr.
can be
Amol, your slides are not shared. Huh?
I will just, can they be seen now?
Yeah, now we can see them.
Yeah,
Yeah.
I'm sorry. Yeah. So, hello, I'll be talking about the clinical aspects of the ultra-hypofractionation radiotherapy in breast cancer. Now, we will, before we go on to talk about the radiotherapy treatment, let's go through the history of the radiation treatment in the breast cancer and how we adopted the new protocol of ultra-hypofractionated radiotherapy. Now, before the radiotherapy treatment, let's understand how the non-metastatic breast cancer patients are managed. They are either the patient at the presentation can be an early breast cancer or a locally advanced breast cancer. Early breast cancer patient can undergo surgery in the form of either a breast conservation surgery or a mastectomy. For patients who have a locally advanced disease, may undergo a surgery upfront, or if the patient is willing for breast conservation, can undergo for a neoadjuvant chemotherapy for reducing the size of the tumor, and then can undergo a treatment with conservation surgery, or if happen, it may be a mastectomy also. After the surgery, based on the histopathological features of the tumor, patients received the adjuvant chemotherapy treatment, or also the based on the hormone receptor status and HER2 new targeted status, the treatment targeted therapy is given. It is during this time this patient also are planned for adjuvant radiotherapy treatment as per their clinical information. This is an NCCN guideline for the indications of radiotherapy in breast cancer. You can see on your left side is a patient who undergo lumpectomy or breast conservation surgery, and also the lymph node dissection status. All the patients received adjuvant radiotherapy treatment. In case on the right side, the patients who undergo mastectomy, maximum number of patients receive radiotherapy, but if a patient has a tumor size of less than or equal to 5 centimeter, node negative disease, and the margins are clear, then in that in those patients, there is no indication of radiotherapy. So most of our patients from this chart, you can know that require radiation treatment. Now, what is the evidence that showed that why radiation treatment should be considered in breast cancer? So this information, the evidence has come from the meta-analysis by ABCTCG, which is the early breast cancer trialist group. They studied on more than meta-analysis of more than 17 randomized trial and more than 10,000 patients, and they found out that there is improvement in the local control as well as reduction in the breast cancer mortality at 10 years when these patients receive radiotherapy treatment. The treatment that was the radiotherapy treatment that was given or used at that time was a conventional fractionation of 50 grain 25 fractions over 5 weeks. The hypothesis was that the breast tissue is less sensitive to the changes in the dose per fraction. But this was always studied, and was always there was always a dilemma that whether this holds true for breast tissue. And there were certain pilot studies which were done right since 1993 in UK and Canada, which said that breast tissue does have a sensitivity to changes in the dose per fraction. So this hypothesis became a background for a landmark study which was published in 2003 by UK. Now this is the START B trial. I will be talking about the START B trial. There is a START A version also, but that is a little less relevant here in our current webinar. So let's talk about START B trial. In that trial, more than 2,200 patients were randomized into the standard arm, which was 50 grain 25 fractions over 5 weeks. And the study arm was a 40 grain 15 fractions over 3 weeks. So this was an hypofractionated, or we can say a moderately hypofractionated radiotherapy treatment, 5 weeks versus 3 weeks. In this chart, you can see on the left side the results of this study. On the left side, if you see this graph, you can see on the y-axis, it is the ipsilateral tumor relapse. And on the horizontal axis, it is the years of follow-up up to 10 years. The upper red line is a 50 gray conventional fractionation line, while the lower one or lower curve, I would say, is a 40 gray fractionation 3-week regimen. There is not much of a difference. In fact, there was slightly higher relapses in the conventional arm as compared to the hypofractionated arm, although the difference is not significant. Very importantly, on the right side, you can see that the cosmesis, which we always debate that late normal tissue toxicity is worse in case of a high dose per fraction, but to our surprise, the breast shrinkage, breast induration, or breast edema, which are the parameters of the breast cosmesis, were better in the favor of 40 gram. This is a forest plot, which on in the 40 gram, the breast cosmesis was better as compared to conventional fractionation. There was an hypothesis that when a prolonged fractionation treatment causes more of acute skin toxicity, which was getting converted into a late toxicity. And by the time the treatment of the 3-week regimen was done, these toxicities were not that apparent. So, because of this astonishing results this landmark study gave, many centers across the world, including India and many institutions in India, adopted a hypofractionated regimen because this is reduces the resource constraints on us. A 3-week treatment, a better cosmosis, quick treatment, completion of 3 weeks versus 5 weeks. So this was a protocol that was followed all over the world. But many institutions followed this, but some in certain institutions still continue to treat with conventional fractionation of 50 gray and 25 fractions. And in certain cases it is also relevant to do conventional fractionation. For example, if a patient has undergone breast reconstruction surgery, if a patient has undergone a breast implant, and sometimes in the case of internal mammary nodal irradiation, because of higher doses in the lung area, to avoid giving higher doses with hypofractionation, a conventional fractionation regimen is still followed. So we've followed this protocol in our hospital of 3-week regimen according to this study. Now, what has happened because of the COVID-19 pandemic? We never in our life, everyone never thought that we would have to face this situation ever. And this happened this year, and the healthcare facility all over the world, even the best of the hospital facilities and institutions in the world, was significantly severely affected. And the cancer treatment was much more badly affected because of this, because we know that time is extremely crucial component in case of cancer patients. Any prolongation of treatment can result in reduction in the survival of the patient. And because the hospital was closed and pandemic was there was complete lockdown, the accessibility of the treatment was very less for our patients. So there was a lot of chaos and a lot of difficulty and confusion among everyone's mind that how to go about with the treatment during this situation. There were certain publications that mentioned that we can or the guidelines and recommendations that came up, that what we can do and how we can offer radiation treatment to the breast cancer patients. So this particular paper mentioned that we can do extreme hypofractionation or moderate hypofractionation radiotherapy to reduce the number of visits of the patient to the hospital and ultimately the risk of infection. And in some patients, we might also do delay the treatment or postpone the radiotherapy treatment. But postponing of the radiotherapy treatment had some deleterious effect. As this paper showed that it doubled the risk of local recurrence if the radiotherapy treatment was delayed. So there was a lot of confusion what to do. We have to offer the treatment to the patients, but how to go about it. Now, fortunately, another landmark study from UK was published right during this big issue that we all were facing. And this publication came in April 2020, and it showed some light at the end of the tunnel. This trial is a fast forward study. There is a fast study separately, but we'll talk about the fast forward study in which more than 4,000 patients of early breast cancer with a multicentric trial across 97 UK centers did comparison of the previous standard of 15 fraction radiotherapy with 5 fraction radiotherapy in a week. So 3-week treatment versus the 5 fraction, which is 1 week treatment. There were 3 arms, the standard arm being the 40 gray and 15 fractions, which was a control arm, and the experimental arm B and C, were 27 gray in 5 fractions in a week and 26 gray in 5 fractions in a week. You can see the results of this trial. You see that all the 3 curves are almost looking similar. That means the local regional control. So this is about local regional control. The local regional control was similar in all the three arms. So the 1 week arm showed similar local regional control as that of 3 weeks. And the late tissue toxicities were also similar in the 1 week arm. Now, there was a 27 gray arm and a 26 gray arm. So there was just difference of 1 gray, but still 26 gray in 5 fractions became, in a 1 week became the standard. This is because the 27 gray arm, although it showed similar local regional control, but it had slightly more toxicities, late toxicities as compared to 26 gray arm. So these are results at 5 years, and this treatment protocol came in at right time that we were thinking about how to go about with this treatment, and we adopted this protocol, and we had um, a webinar on this in the month of May this year, where we collaborated with Tata Memorial Hospital for possibilities of application or implementation of this protocol in our set of patients. So we have treated more than 60 patients right now with this new ultra hypofractionation protocol of fractions per in a week, and we are happy to share our initial presentation of 35 patients data. In our patient characteristics, we subgroup that to less than 55 years age and more than 55 years of age. We had around fairly 19 patients out of 35 of less than 55. We had patients with lesser comorbidities. Early stage patients were more as compared to the locally advanced stage diseases. Fairly equal distribution of the left and right malignancy. We also had two patients who had a bilateral disease, and also most of our patients received chemotherapy treatment. Tumor bed boost also was given because this patient had undergone a breast conservation surgery. Most of our patients were node positive, that is why they received supraclavicular radiotherapy, and 3 patients received internal mammary radiation dose also. Many patients underwent a breast conservation surgery, and slightly lesser number had undergone a modified radical mastectomy. I mean, this slide, I want to show you how was the contouring. Now, one thing we need to remember is that this protocol, ultra-hypofraction radiotherapy, should be done only at a setup which have a CT simulation or CT-based planning facility. This should not be tried. We will not recommend this for a conventional simulator-based planning. Only a CT-based planning center should go ahead with this treatment. This is because the delineation of the target as well as the delineation of the organs at risk is extremely important when we are considering ultra hypofractionation. In this slide, I wanted to show you that there is a difference between the contouring that we used to do before and now. In this, previously we used to, this is a left-sided patient where a patient has undergone a mastectomy, and we are intending to treat the chest wall. In this, you can see that the chest wall is including the ribs and the intercostal muscle. But this is a CTV. When we used to draw PTV to it, large part of the PTV was involving the lung, as well as there was overlap with the heart, which increased the dose to these structures when we planned the treatment. Now, when but now, because there is a change in the contouring guidelines, and there are certain ISTRO-based guidelines which show that there is very unlikely chance of a local recurrence in the ribs and the intercostal area, and only the recurrence is in a post-op case is seen on the soft tissue around the tumor area. That is why the edge or the posterior margin of the CTV comes anterior to the ribs and the intercostal muscle. This reduced the amount of PTV going into the lung and the heart area. For the intact breast, there is not much change in the contouring guidelines. They are more or less the same. But in this example, I would like to show you the patient on the left side and as compared to the patient on the right side. What is the significant difference between the two is that size and volume of the breast tissue. You can see that on the left side, the breast is quite bulky, and as compared to the right side. This is because when we initially started our treating our patients, we started for all the patients with ultra hypofractionation. But we found out that those patients who had bulky, large breast or the pendulous breast and a large inframammary fold developed the acute skin toxicity much earlier and slightly on the severe side as compared to the patients who had smaller breast tissue or breast volume. So that is why this we took a clinical call at the time of evaluation in the OPD, and those patients who had a bulkier breast, larger inframammary mammary fold, or a pendulous breast, we did not offer them the treatment of 5-fraction radiotherapy. So the protocol that we used for the treatment of our patient, for the patients who underwent breast conservation surgery, this is in line with the recommendations and the guidance also from that webinar that we had from with the Tata Memorial Hospital. And for the patient who underwent breast conservation surgery, the total breast dose was 26 gray in 5 fractions in a week. These patients also received a simultaneous electron boost of 6 gray in 5 fractions. Now, why there is a difference between the boost dose that was planned in the fast forward protocol. In the fast forward protocol, they gave a sequential boost, but because to avoid the visits of the patient, we considered for a simultaneous electron boost. That is why the dose was 6 gray in 5 fractions for the electron boost. And this, the BD of this is exactly similar to the one which was in the fast forward protocol. While the post mastectomy patient received 26 gray in 5 fractions in a week, and no bolus was applied unless there was involvement of the skin. Those patients who had supraclavicular fossa or internal mammary radiotherapy, they received the radiation treatment as per clinical indications. Now, this slide I wanted to show you how we did a plan optimization. So after a contour was drawn and a PTV was given for the physics planning, the standard treatment beam plan was made. Although whenever there was higher doses to the heart or to the lung, then with the help of a clinician, we used to sit with medical physicists and optimize the plan to obtain a good achievable treatment plan. Now, these are some of our doses that we have compared with the fast forward study. In this, the 90% of the volume should receive greater than or equal to 95% of the dose. We were able to achieve our average of 92%. It is slightly less than what was recommended, but we need to understand a key difference that was present in the fast forward study is that they made the PTV contours based on a field based design, while we followed the anatomical guidelines, the standard contouring guidelines, and that is why the average dose is slightly less. The 105% dose receiving volume should be less than equal to 7%. We were able to achieve significantly less, or which was just less than 0.5%. We also managed to keep the skin dose, the skin surface dose, as low as possible, below 105%, to reduce the skin toxicities during the treatment. None of the patients received a dose of 107%, and the Dmax we achieved was 105.4%, as opposed to which was recommended less than equal to 110%. The ipsilateral lung dose of volume receiving 8 gray should be less than or equal to 15% as per the trial. We were able to achieve it slightly higher, about 16.5%, and this is again primarily because of the lesser optimization and the PTV, and primarily because of the PTV that was exactly not the same as that of the trial. And volume receiving 7 gray of the heart should be less than or equal to 5%. We were able to achieve 8.27%. Now, this is again slightly on the higher side, but we were not doing the deep inspiratory breath hold because of the pandemic situation. That is why this was slightly on the higher side. But the other parameter, which was, so the second constraint which could be achievable was 1.5 gray less than or equal to 30%. We were fairly and very well able to achieve it significantly. Some of the parameters, other parameters that we documented was the contralateral breast mean, which was less than 0.08 gray, and the spinal cord dose for supraclavicular fossa radiotherapy, the max dose was 18.5 gray. We also recorded a skin dose of 11 gray in our patients. Now, when we followed our patients with the skin, with the acute toxicities, now this is a graph which shows the acute skin toxicity as per the CTCAE criteria. On y-axis, you can see the number of patients. On the horizontal axis, you can see the duration of the radiation post treatment duration at conclusion: 2 weeks, 4 weeks, 8 weeks, and 12 weeks. In purple or pink is the grade 0, in green is grade 1, yellow is grade 2, and red is grade 3. You can see at conclusion, many patients, like 86% of the patient, had no skin toxicity at all, and very few, like 14%, had grade 1 toxicity. But at 2 weeks, at 4 weeks, you can see there was rise in the grade 1 toxicity, appearance of the grade 2 skin toxicity, and it continued to be there even up to 8 weeks. So there was a gradual rise in the skin toxicity. Two patients suffered grade 3 toxicity. One was a chest wall, and the other patient was a intact breast. The chest wall patient, we identified that it was because of the bolus that she suffered a skin toxicity, and the other patient was a bulky breast, as well as the patient could not follow our skin instructions properly. But all the patients were given the treatment, and over the time, after 8 weeks or so, all the toxicities regressed. Similarly, we're talking about the dysphagia, the patient who received supraclavicular fossa radiotherapy. Many patients did not have any difficulty in swallowing, but at 2 weeks and 4 weeks, there was gradually appearance of slight pain while swallowing, and some patients also had to change their diet to take it semi-liquid diet, semi-solid diet to for swallowing. So very few patients, 6%, 3%, and 6% patient over time develops a little bit more dysphagia, but again, that also settled after 8 weeks. Some patients complained of pain in the breast and the chest wall region. That at the conclusion, nobody had these symptoms, but there was appearance of the mild, moderate pain as well as a slightly severe pain at 2 weeks in some patients. But many of the patients developed these resolving of these symptoms of pain. We also documented presence of fatigue in our patients. Most of the patients did not have any fatigue. Some did have at 4 weeks and 2 weeks. So if you can see the trend of all the acute toxicities of skin, pain, fatigue, or presence of dysphagia, most of them in this ultra hypofractionation arm are appearing about 2 weeks after the radiation treatment has been done. And then it is gradually rising to some extent, and then they are resolving. So this was a unique observation that we were able to make when we were treating this patient with ultra hypofractionation. All our patients were given good dietary advice at the beginning of the treatment. Skin care and counseling was done. Topical steroid cream application. So initially, when the patients started developing the skin toxicity, we advised them steroid cream. But later on, we changed our narrative and counseling of the patients, that we told them to start applying this topical steroid from the day one of the start of the treatment, and continue that application at least up to 2 weeks after completion of the radiation treatment. And we found out that this strategy was effective and in reducing the skin toxicities to a greater extent in these patients. Patients were also given topical anesthetic drug if the patients were having complaints of dysphagia at the time of swallowing. Thank you very much.
Thank you very much, Dr. Amol, for that very detailed analysis of our experience. And as Dr. Amol mentioned, we've treated around 60 odd patients, and he presented 35 patients data. And these are patients in whom we have around 2 months of follow-up data. Now that we know that the fast forward trial is effective, we have Indian context of it being very safe in our patients and very well tolerated. We would like to share with you now, how did we do it? There have been certain nuances, like for example, for electron boost planning, when we were doing 20 fractions, we were planning the boost in week 4, but here we had to plan the boost on the very first day itself. So how did we do it will be the second part of this presentation. My colleague Sunil Maurya, who's a radiation therapist, will talk about first the simulation part of it, and then my another colleague Anand Jadhav, who's a physicist, will talk about the planning, and then Sunil will come back with the treatment part. Sunil is very passionate about stereotactic radiosurgery, and we are very happy to have him on our board. He brings a lot of experience in SRS, and you will hear him about the breast experience as well. Over to you, Sunil.
Yeah. Hello, friends. Good evening. As Mr. Jarian and Dr. Amol has explained you about COVID-19 situation and how we were maintaining the treatment of our regular patients. So I would like to elaborate the simulation process of ultra hypofractionation and how we were doing that. So that includes, the first thing is the simulation. The most important part is the simulation, because we have to maintain the same setup what we are doing on the simulation time. The same will be maintained for the treatment. So what simulation process includes that the first thing and the most important is identification and their diagnosis. The identification is important because we have to exactly simulate the same patient by identifying with their full names and the date of birth. And even some hospital follows with their UHID. The diagnosis is also an important thing because we have to see the exact location where it's a left-sided or a right-sided along with SCF, and the electron boost is there or not. So after that, the second thing comes in the part is verification of the documents. So right now, because of this pandemic, we have started to verify documents of two extra add-on documents, which includes COVID-19 RT-PCR reports and a COVID declaration form, which was shown by Mr. Jerin in his previous PPT. And the other documents are like the clinical notes and the consent forms will be verified before the simulation process start. Then we have to explain the entire simulation procedure to the patient before taking in the CT room, because the patient has to be comfortable with entire process, whatever will be the happening with him. Because the thing is that we will be completely in PP, and even patient does not recognize that the person who has explained he will be doing the same or not. Then after the simulation, we will be collecting all the required documents like mammography reports and earlier case reports of surgery, whatever patient has done prior. So and after the documents collection, we will be allotting the patient treatment time, because sometimes we might start the patient treatment on the next day, but most of the time most of the cases we have started the treatment on the same day. So that also very important because of the hospital COVID protocol. So the simulation process for ultra-hypofractionation breast cancer we have done for the intact breast and chest wall. So intact breast, once the patient gets familiar with the simulation process, we take them for a CT scan. And the immobilization what we use is a Sivco breastboard along with the patient arms overhead with their comfortable position. And after that, we delineate after alignment of the patient, we delineate the palpable breast tissue with the copper wire along with the tumor bed marking. Then we place 3 reference marker on the patient body, and then we take a scan of 3 millimeter thickness from mandible to umbilicus. Then similarly for chest wall, in chest wall we used to mark the entire scar region and opposite side of opposite breast for the contouring. So after the chest wall, the most important thing is electron boost marking, which we used to do on the same day. Why we do that? To give the radiation dose to the tumor bed. But how we are doing that? So most important thing in this is alignment of the patient, because we want the position where we have to give the radiation a flat surface. So positioning plays a most important role in that. So for that, we used to give a 0 degree slant with a small wedge cushion below the patient to make the patient area of treatment flat. So patient will be lying in a unilateral position, and the marking of the treatment area will be done with the help of mammography and its reports. And the CT scan of 1 mm slice thickness will be taken for that area, which will be in that we will be defining seeing the surgical clips, and based on that, appropriate field size and energy is defined by the clinical reference by the doctor during the simulation process. So this includes all the simulation procedure what we are following right now for the breast treatment. So over to planning, I am handing over to Mr. Anand. He will be talking about on planning part.
Many of you will wonder what is so special about radiotherapy planning of breast cancer. We have been doing it for a while, but trust me, from the ultra-hypofractionation point of view, we need to be far more careful. Sunil, you may want to stop your screen sharing. Yeah, now yeah. Anand can do. So Anand is our medical physicist, and Anand and our team does a great job of planning not just breast cancer patients, but most of all of our other conditions also. We follow a slightly different philosophy in our hospital. We don't generally rely on the recommendations that are given for the constraint. Say, for example, if the spinal cord constraint is 46 gray, we limit that to around 28 gray in head and neck cancer patients. So we try to follow the ALARA principle as low as possible, and that has been giving us excellent results. So I hand over to Anand for giving us a detailed view of how the planning is done in ultra-hypofractionation patients.
Yeah, hi. Thank you so much. And thanks my colleague, Jarin, Sunil and Dr. Amol. You have made my job easy. You have done tell everything about the ultrafractionation. So I don't waste time on ultrafractionation. So this is not ultrafractionation. It's known as a fast forward trial also. This is not any RTUG protocol or neither ASTO or ISTO guidelines. This is a UK based trial which was conducted in UK and published result in April 2020. And then we decided to go for the fast forward trial. So everybody knows, if we are aware, we have started our career in radiotherapy. So we know that the patient for breast cancer treatment came to the department for almost 25 to 30 fractions, almost 1.5 months. And there's revolution come in radiotherapy. We change treatment modality from conventional to 3D CRT confirmed radiotherapy. Simultaneously toxicity goes down. Simultaneously that toxicities go down, then number of fraction also goes down. It's come to the hypofractionation. Now 25 to 15 fractionation. Now it's come down to 5 fractionation. It's known as ultra hypofractionation, and it is more equivalent to the 40 grain 15 fractions. So before we go for the challenges, if you look at these slides, what the fast forward trial is going to say. If you look at this slide, they have mentioned how to draw the contour, and they have made the planning field-based contouring. So what does it field-based? So they have drawn the CTV on the CT data set, and they put 2 appropriate tangential beams, those who cover the breast tissue, and minimize those to the OAR. So they scroll down from top to the bottom, and they have drawn the PTV inside the beam, 2 beams, tangential beams border. So there is a guidelines for contouring. They have mentioned in trial that your PTV should be 5 meter crop from the skin, 5 millimeter crop from the lungs, and 5 meter from the posterior edge of your beam, and 10 millimeter from the superior and inferior beam edge. So they have made the guidelines for contouring. So if you follow the same guidelines, you try to encompass your PTV in that border. So you will be able to achieve that constraint what they have mentioned. So these are the guidelines for prostate and chest wall as well as the same. If you have in chest wall, if the skin is involved, then you have to contour like this in left side. And if the skin is not involved, then you have to follow the same guidelines that 500 crop from the surface. So while doing the DVH analysis, you have to draw the ipsilateral lung separately instead of total lung, heart and controller base for reporting. And what are the challenges? When we decide to go for the ultra-hypofractionation trial in our hospital, we decided in April, and we treated the first patient in May. So before we go ahead, we are in a worry whether we would be able to achieve that constraint, that stringent constraint, because we are going to deliver more than 5 gray in a single fraction dose, and we don't want to be give the higher doses for OAR. So these constraints are very stringent. So we have done the lot of planning on our existing patients, and we got the enough confidence that we can go ahead and we can achieve this constraint. So there are the challenges, and even the fast forward trials, they have only limited data about the constraint for breast and SCF, IMN, bilateral breast and boost planning. They have given the instruction how to do the boost planning, but they have added the dose for the constraint table what they have given. And biggest challenge is, because in our hospital protocol, when patients come for the treatment, they have to go for they have to undergo for COVID test, and that is valid for 1 week. So we have to do the simulation planning and starting on the same day. That is the biggest challenge for start the fast forward trial in our institute. So what are the constraints? The constraint they have given for this is for mainly for lung and heart. They have given the dose received by 30% of the dose received by 30% of the prescribed dose. It should be less than 70%. That comes for 8 gray should be less than 15% of the volume. That optimal. And for heart, it is 1.5 gray should be less than 30%. That 25% of the prescribed dose should be less than 5%. And 5% of the prescribed dose should be less than 25%. It comes 7 gray should be less than 5%. And that for PTV whole breast, your at least 95% of the prescribed dose should be received. 95% of the volume should be received by 95% of the prescribed dose, and that should be the global max 105 should be minimized up to the 7%, and 107 should be less than 2%, and try to avoid Dmax less than 110%. So this is a strategy we used in our hospital, that volume received by breast more than 95% of the prescribed dose, and if we try to cover tumor bed is completely 95% dose. And when we started this trial in our hospital, this in conservative base we are able to achieve the constraint and coverage also, but in chest wall we find the difficulty. So that time we optimize the plan along with oncologists such a way that that plan is optimum, and the coverage will be remain same, and we will manage the constraint for OAR, lung and heart. So that all this plan be finalized by the oncologist. So we used to do in our hospital 3D CRT field in field plan technique for all the breast, for breast and chest wall, and there is a dual isocenter technique for breast and SCF. SCF we use the SSD technique, and we will describe the dose in breast for at isocenter and SCF at reference point. So these are the few snapshots from our TPS that we have done in for, these are for lab based. If you see that our beam, the tangential beam, we have keep the tangential posterior border very close to the posterior border of the breast in for right also. So there is, you have seen that medially there is a, sorry. So for medially there is a little bit compromise. So because of the clinically relevant, we have decided we sit with the oncologist and then we go ahead. So this is for the chest wall. This is for right chest wall. And so this is the dosimetric data. We try to put main to tangential beam and put field in field for homogeneous dose distribution and to reduce the hotspot. When we started this trial, we found there is two cases, two patients where they get some skin reaction. One is with bolus and other one is without bolus. So then we later decide that we keep maximum dose below the 105 on the skin surface and try to keep low dose as max dose as low as possible. So if you see that as the fast forward trial is mentioned that dose received by 90% should be more than 95%, but ours is 92%, and 105 is only 0.5%, and there is no 107. So ipsilateral length 8 gray is also slightly little bit high, because we have not used any DIBH for left side cases. We used only for without DIBH, and it could be when we start our DIBH, it could be might come down that left lungs and heart doses below this constraint. So that we are going to do it in next coming patients. So these although already Dr. Amol has explained, the mean dose for controller lung and controller base is very, very low. Spinal cord is also 18.5, that when the SF was involved, and the skin was mean dose is also 11.04. So yeah, in conclusion, definitely if you use the proper beam selection and energy, that energy we used to for planning 6 and 10 mu depend upon the breast thickness, and we used to do the plan optimize with along with doctor, so it get your confidence without compromising your breast tissue and OAR also. So definitely everybody can able to implement this hypofractionation in institute following these guidelines. Thank you.
Thank you, Anand, for that quick overview about the planning. Over to you, Sunil, again, talking about therapy, the treatment aspect of it. I mean, we are giving a very high dose to the patient, so giving it most precisely is very important. And Sunil will share with us, how do we ensure the accurate delivery of this treatment in our institute?
So, thank you, Anand sir, for explaining the planning process. So after the approval of plan from the oncologist and the physicist, the most important and very crucial part comes for the therapist to approve and check the plan before executing. So in our institute, we have treatment approvals for the before the patient getting inside the treatment. We have two steps. One will be approved by the therapist 1, and second will be approved by the therapist 2. So the part that treatment approval done by therapist 1, who will be seeing all the documents, whatever we have uploaded during the simulation process. You can see here the first one will be supervised by a therapist 1, and all the documents after the approval of therapist 1 will be again reviewed and approved by the therapist 2. You can even we can see you can see here that all the documents like clinical notes, COVID reports, COVID declaration form, and the consent forms have been properly uploaded and verified by the both therapists. And we have to schedule all the sessions of the treatment along with the imaging protocols, and all will be done over here. And after that, a checklist will be filled, which includes all the patient details in that billing, patient billing status, and consent forms are there or not, and even patient demographics, and the fractions are being changed from the new start to end fractions, and there is any protocol of bladder or rectum. In breast cases, we have used a bolus or not, we have to use like that, all will be mentioned, and patient weekly OPD review will be mentioned. So after this both approval, the second most important thing is the same therapist will go for OSMS data import. In that also, this also plays a major role, because during the setup of the patient, when we are setting up the patient, we also set with the help of OSMS data, which reduces our exposure time with the patient and gives a good result for the setup of the patient. So in that, while importing the data, the selection of the patient is very important thing, because we have to see the proper site and diagnosis. That is, if it's the patient of a right breast, so we have to check the input data which is coming from the TPS is a right side only, and the diagnosis in that we have to check even if the SCF is there or not, and if the data is been proper uploaded. Then adequate, we have to delineate the entire area with adequate region of interest mark area we have to define, because when during the treatment, when the machine moves and it also drag the OSMS camera, so to avoid that miss coverage, we have to see appropriate coverage and while delineating that area. So patient preparation for the treatment, we have to ensure that the entire process has been explained to patient, which includes machine movements and even OSMS field lights. Because the thing is, when the patient is aligned and the machine moves and patient get distracted with the machine movement or the OSMS light which is coming on the patient skin surface, they will be getting a bit distracted, and a certain motion can make a big changes, because we are delivering almost 5 K on that single session. So immobilization devices and all things has to be explained to the patient for their comfortness and proper alignment positions. So this is the setup what we used to do. There you can see a OSMS light coming on the patient's body surface, which help us for set up the patient. So after setting up the patient, we go for plan implementation. In our institute, we have two-way verification of plan implementation, one with the help of delta shifts, which the shifts we are coming from the TPS, and we after the shifting this value, we can verify it with the OSMS data. While verifying with the OSMS data, whatever position we get, and we can verify with OSMS data, we get the translational and rotational shifts. So before proceeding to the treatment, if we can adjust this shift with the help of that, we can match the we can reduce the exposure of the patient for getting again and again imaged. So this will also reduce our time for patient setup. If suppose we have set on the same what we got from TPS data from the delta shift, then again we have to come inside, we have to reposition. That will increase the patient hour and patient exposure for a more time. So after the plan has been implemented, we have moved forward for plan verification. For this, we are taking orthogonal images, and same will be verified with the oncologist on the day one, and even for the rest of the fractions, we are seeing it. You can see here we have taken a 5 days of data of the same patient, and all the shifts were corrected and they were within limit. So before treatment execution, we are also taking a portal image verification for seeing that breast tissue is exactly covering, the field is covering entire breast tissue area. If there is any mismatch, then we can inform the patient before executing the plan. So plan execution comes in play, then we are executing all the 3 sites of the treatment, which includes the breast treatment, SCF treatment, and even electron treatment. So these are the processes where we are treating the patient. Now moving towards the challenges, what challenges face for the patients during this pandemic? Most important thing is COVID-19 pandemic. Patients are afraid that we how we go to the hospital without getting infected, or they have a fear that if we go to the hospital or we go outside from the our home, then we can get a COVID-19 infection. That is there in the that will be there in their mind. So the second most thing is, in our hospital we don't allow the relatives to come inside the waiting area where the patients are getting seated before their treatment. So they also feel a loneliness over there, because they will be only we are allowing only two patients at a time inside the waiting area, so they can't even correlate in between them. And again, patients are getting more distracted because seeing continuously the pp wearing aliens are moving here and there, because they don't know the same therapists are there on the next day, or who has consulted them, he is there or not. So because of that, they are getting a less of human connections. And the second thing is like extended time for the day one, because the patient will be getting treated simulation planning and treatment on the same day. That takes almost 2 to 3 hours. So patient get distressed also because of that. And when the patient before this COVID era or before this lockdown, patient went for the consulting to hospital, and they are prescribed for the 15 fraction plan or a 25 fraction plan. Now again, after the when the lockdown get little bit released, so patients are coming for the treatment, and when we are offering them this this 5 fraction treatment, then they are getting a bit confused that why this is 5 fraction reduced to 5 fraction, we get any side effects. So they have anxiety for this short course of treatment. Then we are telling the patient to continue their treatment without any gaps. If they have a gaps, like if we are starting the patient on Monday, we have to finish them before Saturday, because hospital protocols allow a patient to be get treated for a week. So weekly RT-PCR is mandatory for all patients. Then what challenges faces to therapists? The same again, COVID-19 pandemic, we have to go from home to hospital, we have to travel. That's also a big thing, that infection we may get infection, or we are going in a hospital, we may get this disease. And other thing is PP, that personal protective equipments are also a big challenge for us while treatment of the patient. Even for a long hour duration, we have to wear that, like 3 to 4 hours or 4 to 5 hours in a shift. And then we are easily getting dehydrated. We don't get time for lunch. We don't get ourselves to make comfortable. And the thing is, because of this lockdown and this pandemic, we have reduced the staff. As my colleague, Mr. Jarin has explained, we were running with a less staff department. So there we feel a little loneliness in the department, because only 2 therapists, 1 doctor and 1 physicist will be there. So no means of communication. Then shifts also was a bit hectic, because sometimes we have to travel before the peak time and after the peak time starts. So and the traveling to the hospital also difficult due to lockdown, but a hospital has provided a bus facility to travel. But again, because of the traffics and many things on the roadways, so it was a bit hectic to travel. Then again, chances of getting COVID infection to us or from us to our family is also a big challenge, to maintain the hygiene level and to maintain the self precautions was also a big challenge for us. Then the communication, because of our alternate duty shifts and all, we were having a big communication gap between our colleagues only. Like a week I am doing duty, next week other person is doing duty. So there was a little bit of communication gap, and we have not seen each other almost around 1.5 months. We were not being in touch. Only we were having a telephonic call. Then again, our hospital protocol do a weekly RT-PCR for even staff. So in that, if we turns positive, then quarantine during that infection is also a big hectic process to went through. So what this COVID-19 pandemic challenges tells us, if the battle which faced by the patients, like emotional, physical, or financial, social, and even problems with the family, and most importantly this COVID-19 situation in which the patients are getting more depressed. So what's the role in this? As a radiation, we as a radiation therapist, we can provide them emotional support, and we can explain them the entire process, like how in which manner they can understand in detail, and allow the patient to express their emotions and respond them in an empathetic manner that will improve the patient satisfaction towards us and reduce their distress and anxieties, which will help us for the better treatment environment. So I would like to end this session with a slide. Now you can see here in 2019, we have celebrated a Diwali with a close group and with all the staff. But in 2020, again, we have uh, uh, celebrated it, but in a COVID-19 guidelines way. And everyone was having their mask on. We were maintaining hygiene and everything. But the thing is, because of this lockdown and because of this pandemic, we the new guidelines what we got as a hypofractions, we have treated the patient with this adaptive new protocol. Many patients were treated with effectively and safely. Thank you, and Merry Christmas to all, and Happy New Year.
Thank you very much, Sunil, for that very detailed talk about what are the treatment protocols and how do we ensure that we treat the patients safely while keeping ourselves safe. And what are the battles that the patients faced and also battles that we faced during this crisis. So we all have been through a lot in this year, and I hope that the next year is a better year. We have many questions coming up on YouTube link, and I'm reading them out as they come now. So the first question is, are the staff handling radiotherapy patients undergo COVID test? And if yes, then what is the frequency of that COVID test? I think, Jarin, do you want to take that question?
Yes, sir. Yes, sir. And for staff, they are doing a weekly antigen test for every staff. And if in between you have any symptoms, they used to do this antigen test repeat.
Yeah, and initially we followed that protocol, and then it's an evolving process, as Sunil mentioned, that we all have to adapt, and it also depends on what is the community doing outside, what are the numbers like in the community, and if the numbers are at peak, then we also need to be more careful with that question, with that in that regard. So the next question for Dr. Amol and Anand is that, have you used DIBH in left-sided breast cancer with ultra-hypofractionation?
Dr. Amol will be.
Yeah. So in this current pandemic situation, although we always used DIBH, deep inspiratory breath hold, for all our patients with left-sided breast cancer, and because it significantly reduces the doses to the heart, but unfortunately, because of this current pandemic situation, we were not able to do a DIBH based treatment for our patients because then it increased the risk of dispersal of the infection through aerosol. At the same time, we also always had a protocol of doing a training for the patients before we actually did deep inspirative breath hold scans. So we could not do it, but yes, we are looking forward now, as we are there's the things are improving now, and we next patients that we will treat for the left side, we will consider doing a DIBH in these patients.
Yeah, in fact, in our institution, before pandemic, every left breast cancer patient underwent DIBH therapy, unless the patient could not, hold the breath or for some other specific reason. Otherwise, everybody was treated with DIBH technique. So we will, hopefully, as Dr. Amol mentioned, hopefully we'll go back to that level again. Are there any dose constraints for heart and other dose constraints for heart and lung same as conventional 50 gray in 25 fractions? Amol, you have actually mentioned those constraints, but do you want to sort of go through them again for everyone's benefit?
Yes, so this protocol mentions that what should be the adequate doses when we are treating with ultra hypofractionation. They have talked about whenever the ipsilateral lung should receive a volume of 7 gray should be less than or equal to 15%, and for the heart they give two constraints: a volume of 8 gray should be less than or equal to 5%, and the volume of 1.5 gray of the heart should be less than or equal to 30%. Now, sometimes it is difficult to attain these dose constraints, and even the trial mentions that in situations when it is not exactly possible to follow these dose constraints, a clinical call can be taken up by the clinical oncologist. So, the doses that they have been mentioned in this, they say that it is as per the linear quadratic model or the alpha by beta ratio that we usually see for all the tissues when we irradiate them. So more or less they are equivalent to the conventional fractionation. That's what it is mentioned according to the trial, and we have followed these dose constraints that they have recommended in their study.
Yeah. The next question is for the nodal irradiation, is it also treated with the same fractionation?
Yes. So, although the trial only mentions about the early breast cancer, and there is not mention or publication of the data regarding the supraclavicular fossa irradiation or the internal mammary nodal irradiation, but in clinical situation, when it is required, these patients were treated with supraclavicular fossa. So yes, we also treated all our patients with 26 gray and 5 fractions. It is similar into line what which was present previously in the 3 weekly regimen of 40 gray and 15 fractions to the supraclavicular fossa. We treated supraclavicular fossa with 26 gray and 5 fraction dose.
And as a policy, we do not treat axilla unless the axilla has active disease. So when we talk about nodal irradiation, we are essentially talking about supraclavicular fossa and very select patients, even internal mammary lymph nodes.
Yes.
However, internal mammary lymph node treatment is very, very difficult. Otherwise, also with hypofractionation, yeah, it's even more difficult. So we have one person who has joined late and has requested you to sort of summarize the whole thing again. But I think, Amol, that we should do at the end when we are winding up.
Yes.
So did you stop treatment for any patients for severe skin reactions? And your graphs actually were quite explanatory for that, if you want to go through them, Amol, again.
Yes. So in our graphs, you can see the toxicities that most of our patients, acute toxicities in terms of the skin toxicity or any other toxicities of dysphagia, actually appeared 2 weeks after completion of the treatment. I mean, it was around approximately 2 weeks after completion of the treatment. And that is why we never face a situation that a patient has developed the skin toxicity during the treatment. Although in some of our patients, when the toxicity was much on a severe side and it appeared like grade 3 toxicities, and it appears slightly more earlier before the 2 weeks, then we sort of shifted our protocol in terms of selecting patients who do not have a bulky breast or a pendulous or a larger inframammary fold breast. So we restrained ourselves from selecting this patient for a ultra hypofractionation, and when any other all patients other than these features were considered for the treatment. So none of the patient actually developed any toxicity during the treatment as such.
And that can be actually sometimes a bit misleading, because what happens is we tell the patients to take care of their skin for around 6 weeks, because we know now 4 to 6 weeks is the time when most people will have reactions. But patients become a bit complacent after treatment is over because they don't have any side effects. And that's the wonderful part about this protocol. So we insist that they take care for 6 to 8 weeks. We also ask them to review in the OPD or on video after 2 weeks to just see how they're doing, and reinforce that they must take care of the skin in terms of wearing loose cotton clothes, not wearing a bra, using a mild soap, not applying any creams or oils on the skin, and using a steroid cream for 2 weeks. Now, this is a protocol that we have sort of come up, and we have a very good experience with this. The two patients who had toxicity, as Amol mentioned, one patient had large breast, and unfortunately, She continued to wear very tight bra and t-shirts in spite of our insistence, and then came with grade 3 toxicity. And another patient had a bolus related toxicity. So the next question is about sanitization of the machine. So Sunil, that's for you. Are any specific protocols followed for sanitization of machine and dosimetric equipment? So Anand could talk about dosimetric equipment.
Yeah, for sanitizing of the machine and all the immobilization devices what we are using. So for each and every patient, when the first patient comes, before taking the patient inside, we used to do all the setup prior to taking patient in, and we have a basilol material, white swab type, which we used to clean entire thing, like from hand rest to knee rest and even breastboard. And even for a head and neck patient, we used to clean all the AIA board along with the headrest and knee rest. So, and after leaving the patient outside, then again, before taking the second patient, we used to do again the same sanitization process for each and every patient.
Yeah, sir, and same for dosimetry equipment also. We used to basosil for cleaning the equipment before using the equipment for QA, and after using that equipment, we asked PCA to clean that all the equipment and kept there properly.
Yeah. And in the beginning of the pandemic itself, we reached out to the vendor, in our case, Varian, and Varian had very kindly shared with us their suggestions of cleaning and sanitizing the equipment. We have been following that. There was a suggestion of using UV lamps in the night, and that sort of was suggested in the beginning, but I don't think that sort of got through. We didn't definitely get it. It was a bit difficult to get it, and bit difficult to implement. And now I don't think it is really required at this point in time. So the next question is, where are patients kept indoors or on OPD basis? So to answer that, all our patients were treated on OPD basis. We normally also do not admit the patients in the hospital for radiotherapy unless the patient is very unwell and is clinically needs radiotherapy. But for sure, no breast cancer patient is ever admitted in our hospital for treatment. We prefer to do that on outpatient basis. In fact, what we do is we believe that the patient needs to be rehabilitated to their normal life. So we start them on our Onco Rehab program, which is a unique program in India, where we have a combination of yoga therapy, physiotherapy, counseling, and nutritional support to our patients. That was initially given offline, in the sense they were physically going to physio department, rehab department. But now we are doing a combination. So some part of it is done physically and some part of it is done on video. So we want our patients to be active and rehabilitate back to their life. So we definitely do not admit them in the hospital, and we encourage them to continue their normal duties while they are undergoing treatment. Many of our patients are in fact working while undergoing radiotherapy. The next question is, did we suggest steam inhalation and drinking kara for staff and patients? As a radiation oncologist, I did not, because I'm not an expert on pulmonology, neither am I expert on Ayurveda or alternative therapy. My suggestion, whenever anybody asks me question about treating COVID-19 or preventing COVID-19, was to please speak to the experts and take the decision. I particularly did not do anything specific to prevent COVID infection. I fortunately haven't had the COVID infection yet. I followed the 3 cardinal rules: hand washing, hand sanitizing, wearing mask all the time, and maintaining physical distance. In fact, we are so used to wearing masks that I'm finding it very odd to see my colleagues on Zoom and seeing their faces, because I haven't seen their faces in last so many months. So we strictly follow these 3 things, which we know are working. There are many other things that people have tried, and we don't know if they work or not. I do not recommend them, in the sense that I'm not an expert, so I'm not authorized to recommend them. And there is one more question for Sunil and Jerin. Significant for reset of the boost planning. So I think the question is around, how do you do the boost planning for these patients?
Yeah, the most important thing is the flat surface. If the during the simulation when we do the markings of the electron field, we make sure that the patient is lying on the breastbone or we on a unilateral position, so that we are providing a small wedge cushion below them or a pillow or any support that patient can lie properly and comfortable position. So after the that we are delineating it with wire and then we mark them, and same we try to maintain on the machine. So hardly we require any resetup for that. One incident happened that the surface was not flat, but it was rectified and we have treated them properly.
The interest is that the surface should be flat.
Flat, yeah.
Yeah, otherwise we'll end up with more reactions and other problems.
Yeah.
We also had, we have had few learnings. So, for example, we had one patient who was actually not treated with hypofractionation, ultra hypofractionation, but we sort of gave a simultaneous boost for her. She received 15 fractions to the whole breast, and last 5 fractions out of them, she also received electron boost because we wanted to cut down the treatment period. We didn't do ultra hypo for her because her breast size was large. Now, in her electron boost, the nipple was included, and she had quite a lot of reaction around the nipple, a grade 3 skin reaction. And so one of our learning was that if you're doing an electron boost along with a whole breast, if possible, we should avoid the nipple area. But many times it may not be possible, and in that case, maybe a simultaneous boost may not be a great idea. Another question I think to you, Amol, is that is the skin reaction result of chemo received before or radiation? How do you sort of, the question is many patients complain of body and skin reaction. So, um,
Okay, so the radiation related skin reactions is usually in the treatment field and the treatment area. Very unlikely that the patient will develop a radiation related skin reaction anywhere else in the body. Although there are instances that because the chemotherapy also has effect on, especially any patient has received some sort of a targeted therapy, the skin reactions or something called as a radiation recall or a skin toxicity can happen. The exaggeration of the skin reaction can happen in the, but this is primarily that happens in the treatment field of the radiation. Very unlikely that it may happen anywhere else outside the treatment field. So it cannot be certainly be said that what exactly is the cause, but any skin reaction that happens post radiation treatment in the treatment field is dealt with as a radiation related skin toxicity, and it is managed accordingly.
yeah. We did have one patient where she had a skin reaction and she had received chemo. She actually received radiation, and after 1 month
After
or
that
so, then she
chemotherapy.
received one cycle of chemo. And
Yes.
almost 2 weeks after chemo, she had quite a bad skin reaction. So,
Yes.
maybe there was some synergy happening there, unfortunately.
Yes.
So next question is for you, Jerin. How do you coach DIBH patient before starting radiation?
Okay, before this pandemic, we used to coach this DIBH patient for 3 days prior to the radiotherapy plan, and it was like in alternate days. Okay, so first day itself, we will counsel the patient. We will explain how to do the breath hold and everything. And we will check. We will fix one area of interest, how much the patient can hold the breath. Okay, and we will tell the patient to keep on practicing for the whole day. And second time and third time, we will cross check that patient can able to hold the breath at the same point. If patient is holding the breath continuously and for the same point, then we will select that patient for DIBH, treatment. And the planning will be done on the fourth day, fourth and final day.
Yeah. And other thing that we also do is when we see the patient in the clinic, we teach them how to do the breathing and we encourage them to do it multiple times in a day. And we also have an excellent yoga therapist as a part of our rehabilitation program. And she also teaches the patient certain breathing techniques, pranayam techniques, which helps patients from DIBH point of view. So that has been our experience, and we are hoping to restart our DIBH program very soon as things sort of gradually settle down in this year. The next question is about UV filters. We haven't really used UV filters, and we don't have any experience with that, but we have been practicing what the vendor has told us and what has been the common recommendations, as we have already elaborated. There's one more question about skin reaction. If the skin reaction happens during radiotherapy, do we quit radiotherapy or continue? Do you want to answer that, Amol, please?
If any patient develops a significant skin toxicities, that is, it is either grade 3 and above, and in those patients, definitely we would recommend taking a break of the treatment. But it is very unlikely, and we did not find any of our patient developing toxicity during the radiotherapy schedule with ultra hypofractionation. But if it happens as a rare phenomena in any patients, then if it is grade 3 and above, that is moist discommission other than the fold area, then we might consider giving a gap of maybe 3 days, or depending upon how the healing of the skin toxicity happens. But it is not seen in our setup as far as now.
Yeah. And this ultra hypofractionation protocol is unlikely to cause any side effects during the course of the treatment. And hence, we have to be even more careful because the patient is not going to be visiting the hospital. The patient will not have an easy access to the doctor. So it is important that you make the patient aware that these side effects may happen and equip them for handling them. So, for example, we give them steroid cream for 2 weeks after the completion of radiation. And we also tell them what to do if they develop side effects. We immediately ask them to come and see us in the hospital or do a video call. If the patient develops moist desquamation, we use a gel called Placentrex gel, which has placental extracts. And in ultra hypo patients, we fortunately haven't had to use, but extremely rarely we have used earlier, where patients have had skin reactions, placental amniotic membrane, and that is the best way to treat skin reactions because of radiation. But Placentrex gel does a great job, and we use that in our patients. So as we're coming to almost 1.5 hours into this discussion, I'm going to take the last question, which is, did we treat any patients with added comorbidities of diabetes or other comorbidities?
Yes, we before we recommended treatment for with ultra hypofractionation, we did see the performance status of the patient, and also the age of the patient and the comorbidities. Any patient who was very old and unlikeliness and a lot of comorbidities, not just diabetes, presence of hypothyroidism or hypertension or any other major comorbidities, ischemic heart disease, and if it is a left-sided malignancy in these patients, we restrained ourselves from considering this patient because the anticipation of the late toxicities is still we don't know. And that is why any patient, but most of our patients definitely do have some comorbidities like diabetes or blood pressure, but unless it was very borderline performance status of less than 70 kps, or very old patients whom we might think that may not be able to tolerate if there is a development of toxicity. And at the same time, the how controlled is the diabetes. If it is not controlled, the skin toxicities, if they appear, if they are not managed, then there can be a higher risk of development of infection in those toxicities. So yes, we definitely took a clinical call, and these decisions were made in the OPD consultation.
And that's a very important question, and the answer that you gave, Amol. We have to look at the patient as a whole. Patient is not breast cancer. Patient is a human being who has many comorbidities, and also they may have their emotional needs, physical needs, and they may have lots of questions. So we have to address all of them and not treat them as, okay, I need to treat this breast and get done with radiotherapy. No, you're treating a human as a whole. And as Sunil beautifully explained about the challenges faced by the patients as well as the therapists, we need to be aware of what is happening in their lives and be there for them. A key skill that a healthcare worker needs to have is empathy. We need to understand what is happening in their life, and we need to be empathetic to them. and help them as much as we can and as and when we can. So as we come close to the end of this seminar, so I want to thank all the speakers, first of all, for doing a lot of hard work. Everybody has put in a lot of hard work in obviously making these presentations, but also a lot of hard work has gone into collecting this data and analyzing this data. One person who is not on this presentation right now, who has helped us a lot with analyzing data, is Dr. Tejshri Telkhade. She's a resident with us, and she has done a lot of good work on analyzing this data and helping Dr. Amol to put it together. And thank you very much for everyone who has joined today, for joining and asking these wonderful questions. And we look forward to more questions. Please put them on the YouTube link and we will answer them as we go along.
So
We are also
one more person to thanks for Sanket Patil for organizing all this.
Yeah.
Oh yes, of course. Sanket is very quietly sitting on this Zoom call, but he's the backbone of organizing the whole thing. Thank you, Anand, for reminding me. So Sanket, you were to come on video and show us your face. Sanket has been roaming around the department and making sure that all of us are doing. We are all sitting in the department in different rooms, and he's been
thank you very much.
he's been coordinating with everyone. Yesterday he was on leave, but he still joined our trial session and helped us a lot with that. So that's a lot of dedication from Sanket, and of course the whole team has been wonderful in supporting everyone in getting this on. I also want to invite all of you to join us next month on 21st January. Is that
23rd.
23rd.
23rd January, again a Saturday evening, to discuss about our SRS protocols. We are analyzing our SRS data right now, and we want to share with you how we do it and what are the best practices and what are our results. And we are also going to focus more on the therapist point of view as to what are the things that therapists could do and learn from this webinar. So most welcome to join this webinar, and we'll share with you the registration link very soon. So thank you very much for joining. I hope you have a good Christmas and a very good year end and a beginning of a new year. And I hope the new year brings us some good luck and good health.